Hi there, my name is Terry Burns. I'm one of the tumor neurosurgery faculty here at Mayo Clinic. Excited that you're interested in neurosurgery and excited that you're interested in that program. So about me, I'm from Australia originally, came over in 1996 to play French horn with an orchestra. Evidently never quite made it home because I'm still here, and but excited to be at Mayo Clinic, both running a lab and also taking care of patients with brain tumors. So the patients that I take care of mostly have gliomas, low-grade and high-grade gliomas, as well as metastatic tumors. The practice is mostly operative, but also some gamma knife as well. So these are, of course, patients who have, an extremely scary and time in their lives, feeling very vulnerable. And so it's a privilege to be able to help guide them through that really, really unfortunate thing that they're going through. And that requires a team. And as a resident, you are a really integral portion of the team. So, of course, most of the action for you as a trainee happens in the operating room. And that side of things is actually a ton of fun. So it's an opportunity to make sure that you become the best surgeon that you can possibly become, and the person that I'd want my family member going to, should they ever have need for a surgery in the future. So in taking care of these patients, we leverage any and all resources that can help improve outcomes. We want to remove as much tumor as we can safely, and so sometimes that requires intraoperative MRI, sometimes intraoperative ultrasound, fluorescence-guided resection, awake surgeries, electrophysiological monitoring, and so on and so forth. So you become very familiar with all of those aspects of neurosurgery and tumor resection. But at the end of the day, I'd rather patients not have to be having a tumor removed, quite frankly. And as much as we think we do a great job taking out their tumor, the tumor typically will come back. If it's a glioma, it's going to come back sooner or later. And that's not good enough in my book. We need to change that. And so that's why I do spend half of my time, doing research, and my lab is really focused on coming up with technologies that we can bring to the operating room to change the paradigm. If you think about the way clinical trials are currently done, like temozolomide is what everyone gets at the moment, and where that's been around since 2005. There's not been a single drug in the last 15 years that has improved survival. That's terrible. I mean, that's like embarrassing and so sad, but we can change that. And I think to do so, we have to be able to figure out how to take advantage of access to the human brain that we have. Think about what's going on in the lab. We're asking mice which drugs we should be offering to patients, and they don't have human brain tumors, and it's not in a human environment. So we need to learn, I think, from the best model of a human brain tumor, which frankly is a human brain tumor. But we don't have yet the technologies to do that, and so we need to come up with those. At the moment, we take, for testing a new drug, maybe 100 patients and put them on a trial of one new drug. And some of those patients might be susceptible, others may not be, but they're all tested with this one drug, which makes no sense when you think about the fact that, well, really to solve the problem, it's going to require multiple drugs working in combination. And how do we get there one drug at a time? And so we want to change the paradigm. So what we're really doing then is actually using the response of the human brain tumor to guide our next steps, and figuring out what's working and what's not working, and why, and how we need to adapt. And so at the end of the day, hopefully we would be then actually, having the models to predictively know which types of drugs may be the most effective, and actually empirically screening them using in vivo drug testing paradigms, some new devices, catheters, biomarkers, artificial intelligence. We need it to be deployed against this enemy of the tumor. And so it's an exciting opportunity to really change the way we do things, so that at the end of this process, we can have the patient come in to the operating room and leave a few days later from the hospital knowing what drug is going to work and what's not. We're not there yet. It's where we need to be. And so that's my vision. You will have your own. And it's, I think, one of the exciting things about a residency training program is to have people with energy and new ideas that we're working with. And so our goal is for you to have the mentorship and the inspiration and the opportunities and guidance to realize your dreams, because the torch will be passed to you and you will be the future of neurosurgery. And we want to make sure that you're as equipped as possible to really change the field, because I'll tell you, it needs changing. We're not where we need to be, but we're working hard and working as a team, and it's fun. And I'll look forward to talking with you in interviews, and enjoy the trail as much as it is virtual this year.